Welcome, everybody. You are at our 6th BISI webinar, that is the Behavioural and Implementation Science Intervention Centre with the National University of Singapore, specifically with the medical school here at NUS. My name is Robyn Mildon. I am the Executive Director for the Centre for Evidence and Implementation. I am also a visiting associate professor at the School of Medicine at NUS and have the wonderful job of co-directing BISI as a centre along with my colleague, Professor Nick Sardalis. Today, we have quite a delightful hour for you, and I'm guessing in Singapore it's close to your lunch, so I'm hoping you've got a little bit of food with you ready to go, otherwise it would be very un-Singaporean. We, both Jill and I, are coming to you from Melbourne, Australia today, and lunch isn't such a priority, but I hope Jill has eaten. So to make this a super energetic presentation, I'm going to introduce people now. Firstly, for this particular webinar, I'd like to introduce Associate Professor Tan. He graduated with an MBBS from Singapore and an FRCR. I'm going to have to ask you to explain those acronyms in the UK. He completed his abdominal imaging fellowship at ND Anderson Cancer Centre and more recently an executive MBA from INSEAD. When Associate Professor Tang, when you start speaking, I'm going to get you to talk a little bit more about your background because I know I have totally undersold that right now. Secondly, I'd like to introduce Professor Jill Francis. Jill specialises in behavioural approaches to implementation science, a field which those of you that have been coming to our webinars aims to identify the most effective ways to support changes in healthcare practices and improve healthcare and health outcomes. Of a particular focus, and I have seen Jill speak about this, so we're in for a ride if she goes here. Of a particular focus is the methodological approach to the development and evaluation of complex interventions, something I know a lot of you on this webinar and who have been coming to our BISI webinars have a big interest in. So welcome, Jill. Welcome, Cher Heng. The title of this webinar today is Innovations in Behavioural and Implementation Science for Healthcare, Adding Value and Reducing Unwarranted Variation. Now, we have an extremely smart team at BISI, and they came up with that title and a few extra points. So I'm super looking forward to how we kind of tackle this as a topic together for the next 50 minutes or so. So I'm going to start, if I could also remind the audience, if you have a technical problem, please post it into the chat function. Somebody will come and help you. Please post questions and answers in the Q&A, well, questions at least in the Q&A section or button on the webinar. If you post these as we go, I'm going to be keeping an eye on it and asking questions from the audience during the entire webinar rather than waiting to the end. So highly encourage you to post questions as they come to hand, and we'll try to get to all of them. So Cher Heng, if you could share with us some of the work you've been doing in digital innovations that you're putting in place to drive effective implementation. What's working? What is it? What have you learned? All yours, please.
Thank you, Robyn, and good morning and afternoon to all our attendees. My name is Cher Heng, and I'm a radiologist from one of the local Singapore hospitals, and I currently oversee the research and innovation activities within the hospital, and my job is to try to make the lives and the jobs of the innovators and the researchers a little bit easier by facilitating the administration. I think to that question, there are several examples that I would cite The first would be the hospital's digital transformation strategy. So perhaps more broadly, this is trying to bring in the new technologies in the space of artificial intelligence, the telehealth, and robotics, and various other digital solutions, or at least digital-based solutions that often find themselves difficult to be brought into the hospital system, primarily because they already exist an infrastructure, an enterprise system that therefore needs integration. So what we did with the digital transformation strategy was first map out the areas of adoption in the domains of the clinic. So we have developed a clinic without wall strategy in the inpatient setting, the ward setting, so ward without walls, and various other domains, including rehabilitation medicine, which is one of our priority areas and areas of clinical strength. And what we have been doing in through these what we call strategic innovation programs is to bring together the various stakeholders from across family groups, the doctors, nurses, allied health, from operations, to come in and decide together what the future of care in those domains look like, and how do we bring digital solutions into as an enabler to facilitate the development of those services. And in doing so, we also had to form certain groups to help to support the planning as well as the implementation. So we have formed a kind of a council which helps to look at the approval and the governance of these solutions, and primarily to manage in terms of the knowledge that is being acquired. The other group that we have is a secretariat that helps primarily to guide the project teams in terms of wayfinding, and in doing so, they have developed a playbook of sorts, and that helps them to helps the project teams to be able to know how to get on to the next step in terms of their projects. And most importantly, as I mentioned earlier, the strategic innovation program comprises clinical champions with the clinical need that then allows the projects to have real value in practice. And some of the challenges that we have seen are really in terms of trying to get the solutions past the various regulatory as well as internal approval processes. And so much of the work that we have been focusing on has been to streamline those processes and try to allow permissioning of little sandboxes where we have like a digital innovation committee set up across the hospital to help to support areas such as artificial intelligence as an example. So I'll give a more concrete and specific example. So I'm a radiologist, and in the pandemic, we developed an algorithm that was able to detect the presence of pneumonia on chest radiographs. And we were quite quick in developing the algorithm. What took us a long time was trying to understand how it would integrate with the workflow, how the information, the images would be sent in from the RIS-PACS, which is our image archives, and how the output of the algorithm would then be sent back into the radiology information systems. And in doing so, we had to create a separate kind of a pathway for the data to flow. And this required additional review by the cybersecurity teams. So I guess to that point, one of the major challenges is really in the domain of cybersecurity. I could go a little bit further, but Robyn, I'll pause here to see if you wanted to have any clarifications or you wanted Jill to chime in.
What I want to do is just highlight a couple of things I heard you say then, and probably go to Jill and then come back. One of them is, I can already hear in some of the work that you're doing that you're using what are quite well-known implementation strategies that have been studied in implementation science literature. So one of them that I heard you say, you didn't call it this, but I'm going to call it this, implementation teams. So some of that structure that you set up there, maybe Jill can make some comments on this, is a very well studied and quite evidenced, quite successful strategy you can use to sort of help move an innovation through a system. So I just wanted to pick up on that. The other one is the clinical champions. I'm quite keen to come back to that one. There's been a few projects that we have been part of or are speaking to various groups in Singapore using that as a particular implementation strategy. So let me just give you a little hint that I'm going to walk back to that. And then in the meanwhile, Jill, if you could go ahead, say maybe a little bit more about yourself. I noticed, Cher, Heng, I couldn't get you to do that, so I'm going to get you to do it next time. And just maybe comment on a few things you heard and tell us about your work.
Thank you, Robyn. And thank you, Chair Heng. That was very, very interesting. And hello, everyone. Thanks for inviting me to talk to you today. So I'm Professor of Implementation Science at the University of Melbourne in the School of Health Sciences. My background is as a behavioural health psychologist, so I'm very interested in the behaviour change elements of implementation. What do clinicians actually do at the pointy end of healthcare where they meet the patient, and how is that delivery of healthcare, how can we support the best quality healthcare within that encounter? I also have an affiliate, an honorary position at the Centre for Implementation Research in the Ottawa Hospital Research Institute in Canada, and that's quite a hot spot of implementation research. So I'm delighted to be part of that group as well. I wanted to talk a little. Sorry, Robyn, is that enough about me?
Yes, go ahead. I'll come back. Keep going.
I wanted to talk from the point of my perspective as an implementation researcher on this problem of unwarranted variation in care. And there's a bit of literature on this that I thought I would share with you. First of all, I'm sure you're aware of the inverse care law, which is a term that was coined over 50 years ago by someone called Julian Hunt. According to that inverse care law, the availability of good health care tends to vary inversely with the need of the population served. So the people who need more health care actually get less health care. This is true even in the UK's National Health Service, that tried to override market forces in healthcare by creating a fully publicly funded system. So this kind of variation exacerbates health inequities, and it seems to be a very persistent problem for health systems around the world. So let's just go back to the term unwarranted variation in care. It's clear that this term includes two components. There's an empirical component. We can demonstrate that patients get variable care. And there's a judgment component about what's unwarranted variation that compares practice with views about current clinical evidence. So we need to be aware that sometimes variation is warranted. So personalised care is important. Stratified care is important, where more intensive interventions are offered to people who will benefit most. So the judgment about what's unwarranted is sometimes quite difficult. In this small literature on, not so small, literature on unwarranted variation, it's also been proposed that there are three categories of variation. The first one relates to effective care, where variation implies some sort of underuse for some patients of a valid treatment. Then there's what's called preference-sensitive care, where more than one option of care is available, and variation is around whether the patient was offered a choice. And then there's supply-sensitive care, where the volume of care that's provided reflects the capacity of the clinician or of the system rather than patient need. So these are very, very different levels, aren't they, of variation in care. But any of these types of variation would need an implementation science approach to support more consistent clinical care. But as with all implementation problems, we need to ask how do we know there is a problem? What evidence do we have? So the measurement issue is much easier when we look at patient-level outcomes. For example, we know that there's variation in cancer mortality rates between countries, and we know that there are geographical inequalities within countries. But we do have a problem attributing all of those outcomes to variation in clinical care that's provided in those different areas. Measuring care provided at the level of the multidisciplinary team or the individual clinician is difficult, but not impossible. And the audit processes that health systems use are potentially helpful here. So I fully applaud the efforts in the digital space that Cher Heng has described to us today. So it is possible to identify variation in clinical practice. One example of many is a Danish study of prostate-specific antigen testing, or PSA testing, in general practices. And just to note that PSA testing is not recommended in Denmark. The research team compared outcomes for the men in the highest quartile of PSA testing practices with those in the lowest quartile. There were no differences in overall mortality between the groups. And so the team concluded that the highest PSA testing general practices may not reduce prostate cancer mortality, but they do increase the use of diagnostic and surgical procedures that potentially have very harmful side effects. As well as general practices, there are also measurable differences between hospitals. So, for example, a very interesting study in Japan published back in 2012 reported a significant association between physician and nurse hospital staffing levels and what they called failure to rescue, which they defined as the proportion of in-hospital deaths among people with post-operative complications. But healthcare providers work hard. There's no point blaming them for variation in care. Some patients just present greater challenges than others. So it may be that individual clinicians need support to overcome these kinds of barriers. So the implementation scientist asks, for whom and in what circumstances is it difficult to provide care that you could more easily provide to someone else? So I could give an example, but I think maybe, Robyn, my time is up. So maybe I'll hand back to you and we can go to
You're
questions.
both being very, very polite. Cher Heng, did you want to pick up on anything you heard Jill say there? I saw you nodding your head a couple of times, particularly around variation or unwarranted. Is there anything you want to add to before I build off that?
Yeah, a quick one. I think quite a bit of the variation also occurs because of patient factors, particularly where there is concern for medical legal liabilities, where the patient requests for certain either a procedure, an imaging test, or even a therapeutic procedure. The physicians sometimes feel compelled to be ordering something for the patient because the patient has asked for it. And this compounds the problem of variations on top of whatever Jill has alluded to.
Yeah, I totally agree with that. And this whole issue of patient choice, very, very important one. But of course, the key issue for the clinician then is how well informed is that choice? How well have we done at laying out the evidence base about benefits and also about potential harms? And how well do we share that information with patients? And so there still is a piece of work to be done potentially to make sure that, in the worst case scenario where there's a defence needs to be argued, that the patient was completely well informed. If the patient proceeds with requesting that particular care, then our ethos of healthcare would say, well, that's appropriate, as long as it's a very well-informed choice.
All right.
Sometimes the challenge of informing a patient, sorry, Robyn, challenge of informing a patient it interacts with patient factors like health literacy, and sometimes it's very difficult. So that's also a potential area of variation in care. I agree with that.
Well, I mean, both of you, it's funny. So digital solutions and implementation plans based on implementation science are both in the same way are trying and should be trying to address health inequality, aren't they? So both of them sort of have come together. So there's a big call, as Jill knows, for implementation science to pay much more to decreasing the gaps around inequality. And Cher, Heng, I'm aware of the digital solutions like that as one way people and systems all across the world are trying to also decrease inequality. I'm getting a couple of questions in there, and I'm going to hold on one because I just, Cher, Heng, I wanted to come back. There was, obviously with what you're trying to do, and it goes to a little bit about what Jill was saying, you're trying to implement a solution in a system, and digital solutions are notoriously difficult to get uptake and implementation with, notoriously. People kind of start well and then they sort of dip quite quickly. But I know when we met, you were talking about some other strategies you were putting into place. This is where you might want to talk about the clinical champions approach or a few others. I'm just interested in some of the kind of value add implementation strategies you've deliberately put in place to try and overcome some of the well-known implementation strategies. I mean, you can probably hear that bird in the background. So that's just, that's joined the webinar. I can't do very much about that. I'm going to throw a pen at it. I won't hurt it. Go ahead, Archie. If I throw something, I'm trying to distract the bird. Please go.
Yeah, Robyn, thanks for that question. And really, these are very real problems, ground issues pertaining to whether or not the practitioners, and in this case, I mean not just the doctors, but the nurses and allied health who have domain knowledge. They interact with the patients and the system and the services. They know where the problems are. And the big issue for many of my colleagues here is that they have no time. And in trying to drive a project, it often requires them to use their own personal time. And it's not just doing the work itself. It's about thinking about the problems and the proposed solutions and how to bring those solutions into mainstream. And that's why we need the champions, because the champions are the ones who are first, the ones who can recognize the problem, frame it, and then try to relate it to whatever solution that we are trying to devise, and try and bring it all together into their areas of practice. And that's why I mentioned there was that need for us to create a council for permissioning, to create a sandbox for them to do their projects in. So that's kind of risk mitigation at a systems level. But at the ground level, the champions are particularly important because they are the ones who will then be able to relate whatever they are doing to what they foresee or what the system in the future should really be doing. So let me give an example. The rehab medicine team in the hospital had been working with the engineers on creating a robotic solution to help the patients who have upper limb weakness and trying to rehabilitate their post recovery from say stroke. And it is not really the device that was the problem. It's actually really trying to bring it to mainstream. So there are numerous steps that the clinicians need to do. They need to first devise that solution together with the engineers. And then they have to test it on the patients to show clinical efficacy, and that's all well and good. I think the big challenges now and very often cause frustration in among the clinicians is trying to bring that solution into the hospital system for that device to be able to talk with the enterprise systems for data to flow in to the electronic medical records. And then there are questions around the willingness to pay. How do you make this into a mainstream service where it is sustainable? And there are all these problems where without a champion, you probably kind of stop at the product development and not being able to translate into adoption and implementation.
Very, very good. Jill, do you want to make a couple of comments on that? Otherwise, I have a specific question for you building on there. Was there something?
Yes, I have a comment. Thanks very much, Heng. When you think of the number of dollars that are spent in the development work for some of these digital solutions, which are huge, of course. We do have that sort of sustainability issue. As Robyn said, people can start with enthusiasm and then it sort of fades. And I just think we need to have pay a lot more attention to the amount of waste that occurs if you spend a lot of money working something up and finding that it's effective, only to find that you run out of money to sustain that. And I think it's a problem with all interventions, but I think the digital piece, because the workup is so expensive, is a particularly pertinent problem that we need to have an eye to the cost of ongoing, sustaining that implementation effort after the initial phase. That's one point. The other point, I completely agree about the importance of champions. Champions do, I'm translating that into my behavioural concepts. What champions do are pretty much to say to other clinicians, we'd like this to rise up your level of goal priorities. We know you've got a million things to do. We want this to be one of the most important things to do. And when I do barrier studies with clinicians, one of the questions is, how important is this particular action given all the other things you have to do? And a lot of times people say, well, to be honest, it's not on the top of my priority list. And so the champion's job is to say, well, actually, it is really important. It's more important than other things for these reasons. But to me, as with any initiative that relies on one person, there's a vulnerability there. And whenever an organisation does its risk management policy and creates its risk management table, if there's any job that only one person does, that's vulnerable. The person is sick, the person leaves, tomorrow there's no one to do that champion work. So this kind of comes back to the point that, Robyn, you made initially, which is teams are a really good way to go, because we need someone to be able to step in. We need to be doing that constant capacity building so that there's a group of people that are of a champion team would be quite helpful. And I don't, to my knowledge, there's not really much in the literature about that point.
Well, let me add to that. Oh, no, you go, Cher, you go. Heng, you go.
Thank you, Robyn. I think, Jill, you made a great point about the money being put into development. And that is why I think for the health system to truly succeed in innovation, we really need to be spreading the knowledge in terms of new processes or new products that are taking place in a particular hospital or region, and sharing that with other regions so that people don't end up duplicating efforts. And I've seen a lot of that happen in practice. So we have a very good common use case is trying to determine the position of the nasogastric tubes in the stomach. Tons of teams are working on them concurrently, but people don't share information. So every now and then in a grant review, I will see, the same kind of proposals coming up. And I think this is one of the kind of problems that we have self-created. Grants are very good for trying to stimulate activities in development. But the problem with grants is that once they run out, the solutions very often are then not viable or sustainable. And what we really could be doing is looking out there. The health tech industry is huge and growing very rapidly. And then there are tons of market-ready solutions out there. And so what the Centre for Healthcare Innovation, the unit that I'm working on right now, is trying to do is to create the platform where we can bring those best-in-class solutions in, and for people to be aware and for them to test bid those solutions and bring them into clinical mainstream, rather than people all trying to develop new solutions for the same problem statements.
That's a fantastic point. I completely agree. And wouldn't it be lovely if funders would spot this? And I think they've done this once or twice in the UK. If funders would spot these duplications and say, look, we want to fund you, but you have to work with this team over here because they're already doing the same kind of work. Someone needs to join up these different efforts. But Heng, you were talking earlier about fitting innovations into a clinician's workflow. I think this is a really important point, and it speaks to feasibility of doing that innovation. And I'm thinking a little bit about an implementability framework that we published in Implementation Science in January of this year. Sorry for the plug, but it just does feel relevant.
I'll tell people why I'm smiling in a little bit, but go on, Jill.
In which we're arguing that, that feasibility, for example, could be investigated very early in the development process. So not only is it feasible to develop this and is it feasible to conduct a study, but is it going to be feasible when it's out there after the research funding's gone? Is it going to be feasible to the people that we want to be leaders in the uptake of this innovation? And for that, we need to consult them from the very early stages of development. So really the logic of this framework is how early can you start doing the implementation work, and who do you need to work with to identify whether something is feasible and therefore implementable way after the research funding has stopped.
Well, while I have your attention, and just for people that are on the webinar, the reason I smiled then is when last time Jill and I were working together, I clunkily said, no more implementation frameworks. We've published enough. We got to get on and test them. And she went, well, I have one. So it's just a little joke. Implementation frameworks are awesome, and we think the application of them in both implementation research and in implementation practice really does help all efforts. So it's just contributing to the science, but really also helps with real life implementation efforts. While I have you on the spot, Jill, I want to ask you something I didn't prep you for, so apologies if I'm putting you on the spot. But we're starting to really talk more and more about implementation strategies on this webinar. And just to link it to the idea of feasibility and how doable and feasible are implementation strategies themselves, let alone the innovation. What are some, from your knowledge of the literature, the kind of top 2 or top 3 implementation strategies that we could apply in healthcare and healthcare systems? I can think of one of a joint colleagues of ours that have published, that you would recommend a system that Cher Heng or anyone else is working in. And then Cher Heng, I wouldn't mind you thinking about what Jill's producing and thinking about the feasibility in the context you're in Singapore, because sometimes implementation strategies themselves don't cross countries. Jill, can I ask you to sort of give us the top 2, 3, 4, or however implementation strategies from a science point of view?
Well, okay, so I've got a top 1, but others will occur to me. And this fits with the digital piece because there's a huge amount of work in this area, and that's of audit and feedback in health systems. There's been hundreds of randomised controlled trials of audit and feedback versus no audit and feedback. We know that it influences clinical practice. There's a Cochrane review that says it influences clinical practice, but there's a big but. The median effect size of an audit and feedback intervention is 4% improvement in clinical practice. Now, when you think of how many multi-millions of dollars are spent in audit systems, including digital audit systems across the world, 4% you'd hope we would do better, right? But that same Cochrane review showed that there was huge variation in effect, ranging from about 0 to about 20% improvement in practice. And so there are many ways of doing audit feedback. There's a growing evidence base that shows that if you include certain components, you're much more likely to get up towards the 20% than down towards the 0%. So it's worth knowing the evidence base about how to do feedback. And all digital systems enhance our capacity to feedback to clinicians. But then the information itself that's in that digital structure does not automatically change practice. It's got to go hand in hand with behaviour change techniques and particular ways of providing that feedback so that we can enhance the possibility that we'll get a decent level of practice change.
Before you say anything, Cher Heng, I've got one question I just want to ask. Is there another way of calling audit and feedback? People are terrified of being audited. And then Cher Heng, maybe you
okay, yeah. audit happens, right? Any data that you put into your digital system or your EMR is auditable data. So, indeed, there's quite a few theories and frameworks about feedback. One of the theories says, look out for the perverse effects of feedback. Partly it plays into that fear, because if you direct people's attention towards their reputation, they'll start gaming. They'll respond to the feedback in a different way. But if you are very clear about the purpose of the feedback is to enhance patient care, it's not about making and naming and shaming people who aren't doing the right thing. It's not about that at all. Well, it shouldn't be. It shouldn't be used for that purpose. It should be used for the purpose of enhancing patient care. And whether that feedback is at the hospital level, at the consultant level, at the team level, at the patient level, it's all good information that we can use to enhance care. But we need to say, so what will we do differently in the light of this feedback? And that's the behavioural piece. So any of the electronic systems that give us patient data or service data, we need to be asking that question. So what would you recommend we do differently? And that's where the behavioural component comes in.
Terrific. Heng?
Yeah, very great points from Jill. I think the whole thinking about audit and feedback when it's perceived as a report card of your performance makes people very defensive. And like you say, people tend to game the system because of that. But if it's seen in the light of improvement, and people then become embracing of the feedback and actually want to make positive changes so that we can prevent the next bad thing from happening. So I'm fully with that. And I think I think this is where the hospital has done pretty well in terms of its journey, in terms of quality and improvement, and trying to create that culture of learning vis-a-vis a culture of punitive measures for poor performance. In the space of innovation, I think we are a little bit newer. I think we've all been quite used to pathways and trying to standardize our processes. And so when it comes to innovation, I think people end up not having enough bandwidth and also perhaps enough perspectives to try to innovate. And that's something we are trying to change. I think I would use an example of our new service in 3D printing as an example. So of course, this sits somewhere between and interacting with the digital systems as well as a physical manufacturing of the models. And I raised this example also because we were talking about feasibility and this whole thinking about sustainability beyond a grant. So I sit on the steering committee for 3D printing service in the hospital. And what we've been doing is advising the clinician champions and the support operations as well as administrative staff in building that service. And where they have succeeded has been getting the buy-in of their colleagues in thinking of using 3D printing as a means to educate patients prior to surgery, and even using the surgical guides intraoperatively to improve the outcomes in terms of reducing the operating time and blood loss. Where it gets tricky for us as a steering committee, and I think we would benefit a lot from knowing a lot more about the different frameworks that you have mentioned, is thinking about how we can make this a viable proposal to the management in terms of saying that this program or this new service has real effectiveness. And it's not just in terms of the blood loss or reduction in operating time, but really once you put it into the entire workflow, is there a business case for it? I think we are all quite used to the standard metrics that our business officers give to us. But there are other considerations, for example, medical legal considerations, in terms of the patient's perception of the new service. These are things that we are trying to grapple with and trying to provide some advice. So we kind of directed them to some of the folks in our hospital who have some expertise in program evaluation. But I'm thinking that at the management level, many of these frameworks could become standard of care or standard practice, so that we don't have to advise teams in going about roundabout ways, and we can have fairly kind of standardized approach to how new services, new innovations can be rolled out and implemented for the long term.
I think that's a really nice point, Cher Heng. And just as we're trying to increase efficiency in patient care, efficiency in research, we should be trying to enhance efficiency in implementation. And that, as we've said, I think involves thinking about implementation earlier, and being ready and communicating with people who are the very, very, very end users, which is both patients and management and so on, in hospitals and other healthcare provider contexts. I agree.
I'm going to keep asking from the floor now. There's lots of questions, you two, and some are quite specific, Chair Heng, to the work of your the institute. So I might encourage the team to collect them so you can respond to some of them. But here's a juicy one for both of you, and I'm saving one for the end. So we'll. But failures are inevitable in implementation of any innovative solution. How do we ensure that failures are adding value and not unwanted waste? Chair Heng, you start with that maybe, and then I'll go to Jill. Sure.
I guess I'll give a very kind of unacademic approach to this problem. I think as I shared earlier, the sharing of knowledge across the system in either a hospital or a region needs to be made to avoid duplication of efforts in terms of development. I think the same can be said about failures. If we share the failures that we have had with this particular approach, then others don't have to go down the same way. And today in Singapore, at least, we exist in 3 separate healthcare clusters, and within each cluster, you have different institutions. And some of these are fairly complex in terms of the dynamics across teams. And sharing of information is not always as easy as it sounds. And at the systems or at the leadership level, we do have to make a concerted effort to create those platforms, channels for people to interact, come together and share best practices. And perhaps in this on this topic, also sharing about their failures. And I think we are getting some headway. I think there's recognition across my counterparts from SingHealth and NUH for this kind of a sharing, and I hope that in the very near future we can rapidly accelerate the pace at which we share. And again, this is only just within Singapore, 3 healthcare clusters. We're a very small country. What if we were able to do similarly across the national boundaries, sharing across from Singapore to Australia in a more structured manner, so that we don't end up only holding a symposium or webinar and sharing best practice and knowledge, and then not being able to do so on a regular basis.
Terrific. And someone has very helpfully in the Q&A put a link to the article Jill mentioned of the framework her and her team developed. If that person could put it in the chat, because I think only a few of us can see the Q&A. So if you put it in the chat, everybody will be able to connect with that. And that same person's putting up some very nice calls to action on some frameworks that I think we could do a whole other webinar on failures of decision making and all sorts of stuff. Jill, you want to have a?
I do. Yeah, I do want to talk about failure. Failure, if you're not concerned about reputational risk, failure is an opportunity to learn something really important. And so I completely agree with you, Cher Heng, that if people in organisations are prepared to share their failures, that is one thing. Again, it's in the interests of patient care into the future. If they're not, if they put that goal above their own reputation, very important. The other important thing I think is to theorise the causes of the failure, so that you've got some generalisable learning from that. The very specific learning is okay to a point, because if the particular circumstances that led to the failure can be avoided, the failure will be less likely. But the mechanisms underlying that process that led to failure, if they're better understood, then we've got more generalisable learning. And this whole field of understanding why things go wrong has recently been called developing a dark logic model. Dark logic was first published, the idea was first published in 2014 in the context of public health. And it's basically, the argument is, in a behavioural intervention or an implementation intervention, you might think that it's not like a drug intervention, there's going to be no adverse events or serious adverse events, right? But what if it goes wrong? What if there are perverse effects where you're having the opposite effect that you intended? What if there are other effects on variables that you didn't even think to measure? And so the solution to that is to get, again, a team of people to say, what could go wrong? From the theoretical knowledge that we have, what are the different possibilities that could go wrong? And do that ahead of time so that we can anticipate those issues, but also to share that level of generalisable learning would be fantastic. And, to publish that kind of learning, really important for the field to do, I think. So, yeah, we always look at failure as an opportunity to learn, and it would be nice to have that perspective rather than that defensive reaction.
Cher, you want to add to any of that? You were nodding.
Well, to the last point, Jill, you're so fantastic. I didn't realize there was actually such a thing as dark logic, and it's so well thought through. I think it's also about creating the opportunities for sharing. So what we are trying to do is build a digital database. We call it Child, or a learning and development platform. But this platform alone is passive. It requires people to come together, identify themselves as part of a community, and actively share and promote and exchange ideas about how they can address some of the challenges they face, the learnings they have had from failures. And so while it sounds good that we are, setting up a fairly extensive platform, and we've got hundreds and thousands, actually by now about close to 1,000 submissions, I think the big question I have is about the effectiveness of such a platform. How do we get people truly engaged in and forming those communities of practice proactively without the intervention of the platform provider?
Got it. I have a question each, the sort of the opposite side of the coin for each of you. I'm going to start with you, Jill, and then Heng, you're going to get the final say. So, because there's a fair few questions about what can behavioural and implementation scientists, how best can we work with clinicians in a hospital setting? What do we offer? What have we got to contribute? There's a few questions about that, Jill. So I thought I'd have you respond to that, Jill, first. And then the other way, Heng, how can an institution like yours, what could be useful for you and clinicians and organizational leaders in your setting? What could be useful in terms of what implementation scientists could contribute, all that sort of stuff? And you get the final say. So you get to go out with a bang. So Jill, please go ahead.
Right. What can implementation scientists offer clinicians, hospitals, healthcare organisations? Just to say that I think, clinicians are very busy. We know that they've got multiple demands. Everything that we do with them is going to take some time. And I have said to my clinician members of research teams, how dare you miss my research team meeting by going off and saving lives at the critical moment, of course in jest. So, they're always short of time. So how can we help accelerate the investigations that we need to do to make them pertinent to the problem at hand, but also creating some of this generalisable knowledge? And I think it is about collaborating with clinicians and, by the way, consumers to identify what the priorities are. We can't work on a million fronts at once. So identify priorities and then use our frameworks with the expertise that we've got in operationalising those frameworks to try to clarify some of the problem and the way to go. One framework that clinicians find makes their heads hurt in a really good way is the very simple, what we call ACT framework. To solve this implementation problem, who needs to do what differently for which patient group, when and where? So action, actor, context, target, that's the patient group, and time. And just to specify that is a very simple concept, but actually it's really difficult to do in context because there are so many people who need to do so many actions differently to all come together to result in not only an individual clinician workflow, but a patient pathway. And to make our work more efficient, we need to be very clear on that point. And if we know who the actors are, then we know who to talk to identify what their barriers are. And that might be at any level of the organisation. So I think just the expertise in using the frameworks and maybe fast-tracking towards solutions, because there is an evidence base out there that we can use.
There really is. And let me emphasise, and of course I'm biased, that last point is the literature in behavioural and implementation science has just taken off. There's so much good evidence and research we can use in the work we do, both in designing really, really kind of applied and well-designed studies and in using that science in practice and healthcare systems. So, Heng, tell me how we can help.
So I came into this webinar a little bit uncertain because I'm not an academic in implementation science, but very much a lot of what Jill has said makes a lot of sense to me. I think if I think about how the implementation scientists can add value to our system, I can see it at 3 levels. At the management level, it's about guiding the decision makers on how they can better create the gates for approval for say in the realm of innovation, we have proof of concept to proof of value to what we call implementation or business as usual. But if we only think about the implementation at the end, we are missing out a big chunk of opportunity in the earlier phases. And for the management, it's all about risk management. And if we were able to work in some of these frameworks in the earlier stages of the development, we could then actually circumvent some of the problems that would hit the project teams down the road. At the team level, I think there's a lot of knowledge that we need to understand about how the teams can design validation studies to prove value of the work that they do. And I think at the ground level, it's about patients, actually, really. I think very often we see it from the provider's lens, and we don't think enough about the patient's perspectives. And I think this is where a lot of what I think, and Jill alluded somewhat to it, can be done from a more structured and methodical approach in terms of addressing patients' mindsets and receptiveness. So in all these regards, I think implementation science can have a huge role to play to facilitate the work that we do.
Excellent. Any final comments from either of you? Something burning that you wanted to say earlier, some message you want to say? We're getting some there's a couple of people in that Q&A very busily finding these articles that everybody's talking about and posting on the chat. So please,
thank you.
Please grab that. But any final words from either of you?
Yes, just to say, Robyn, as I've heard you say many times before, implementation science is a team sport. And so it's all about collaboration, and no implementation scientist rides into a healthcare organisation and changes things. It's always done collaboratively. I've got a bit of a bugbear at the moment that, yes, it's done collaboratively with clinicians, but implementation hasn't actually occurred successfully until the patient has engaged with the innovation, as you've mentioned, Chair Heng. So in my mind, the translation pathway from innovation through to healthcare outcomes has to include the patient as well. So I think it's a very widely collaborative field. We need to listen to one another and talk, and as you say, just create teams and do that priority setting, because we can't do everything.
Yeah. Chair Heng?
Yeah, I think for many of us who are not implementation scientists, it's quite important for us to understand some of the practical application of the academic approach and the rigor to which you conduct implementation science into our practice, and to do it in such a way that, like Jill says, we work as a team rather than engaging a consultant in implementation science to come and help us to get things right. Thanks.
Perfect, you two. Well, what a way to end. Collaboration for all. So I appreciate very much both your participation. I also need to tell the audience, it wasn't like you got a lot of prep. So well done. You really did an excellent job kind of believing in us and joining, and particularly Cher Heng, you saying, well, I'm not an implementation scientist. And I said, but you work in the real world. It'll be perfect. So again, I appreciate the time of both of you very, very much. Appreciate the audience. Appreciate all the questions. Sorry, very, very sorry we couldn't get to them. As I said, some were quite specific, so I'm hoping the team have captured them. Articles are online. We'll see you all soon. Come back if you have any questions. Thanks again.
Thanks, everyone.
Thank you.